Welcome to our launch webinar for the new Strengthening Medication Safety in Long-Term Care Ontario initiative. My name is Carolyn Hoffman, and as the CEO of ISMP Canada, it is my pleasure today to join with a number of our staff to talk with you. I'd like to begin with a Toronto land acknowledgement. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. I invite all participants to insert their land acknowledgement from wherever you're from into the chat box. During the session today, we have a few learning goals. We hope by the end you will understand that there are a number of tools, education, and coaching resources available through this initiative to you and how you can access them, how residents and families can help increase the safety of the medication management system in the home, how the quality improvement curriculum enables homes to improve medication safety, and how changes have been made to the medication safety self-assessment program for long-term care, and how that tool will help you evaluate your medication systems, plan improvements, and monitor progress over time. We are going to take a deeper dive now into these areas, and as we move forward, we want to reflect on why do we need this initiative. It's very important for us to talk about the why as we advance the desire and the activities for improvement. There are many different reasons why, and 3 of them are here for you. Residents are prescribed more medications than individuals in any other setting in order to treat multiple medical conditions. The number of drugs prescribed to a resident, as that number increases, the risk of adverse drug events and harm also increases. Medication management is complex and resource intensive in the long-term care environment. I know you know that, and I really encourage you to share in the chat box some of your challenges, some of that complexity, so we can interact and understand what's going on in your home. And with that complexity and resource intensive aspect, it's a key area of risk, but also of opportunity to enhance safety and quality of life for long-term care residents. Another reason is the report by Justice Gillese in July of 2019 and the vast number of recommendations that she made specifically for medication safety. I'd like to talk a little bit more about that report. The report by Justice Gillese, it was the report of the public inquiry into the safety and security of residents in the long-term care home system. Justice Gillese and her inquiry team methodically gathered extensive evidence into the actions of a nurse that was a healthcare serial killer, and also how the system should change to prevent this tragic circumstance from happening again. The report recommendations regarding medication management systems are integrated into all aspects of this initiative. This report is a powerful call to action for us all, and another big reason for why we need to advance this work. I'd like to take the opportunity to thank the Ministry of Long-Term Care for the 3-year funding provided to ISMP Canada so that we could collaboratively develop and deliver this initiative with homes and other key partners in the sector. And I'll also take a moment to share that the views expressed in this session are the views of ISMP Canada and do not necessarily reflect those of the province. Here you can see Melissa, Alice, Julie, Mike, Anurag, Shirley, and Sylvia from the ISMP Canada staff. They're joining with me in this initiative to engage with people that live and work in homes, those that provide medication management services to the homes, and all the key external partners that care about medication safety in long-term care. You're going to meet each of these individuals as they briefly highlight and do a deeper dive on the initiative and what ISMP Canada is providing and collaborating on with. The ultimate goal of the initiative is to find reduce harm associated with medication management errors within long-term care. That's the specific words. That's our set goal. But now we need to do more than that. A goal is just a goal. It's just words on a paper. We need to imagine a future. We need to imagine where we want to go. I would suggest we imagine a future where no resident experiences preventable harm related to medications. It's a very important future to ISMP Canada, and I know that's a very important future to all of you today. If we imagine that, we can achieve it. There are 4 key areas where ISMP Canada is going to be working specifically, and I'd like to do a very brief overview of those areas, and then we're going to do a deeper dive and give you a bit more information. Here on this slide, you see that overview. The boxes on the 4 corners are the support that ISMP Canada will provide. The 4 quadrants in blue and the home in the center, that's what homes can do with that support in order to improve medication safety. Let's start at the bottom right, where we will provide tools and indicators for measuring and evaluating so that homes can self-assess. They can self-assess themselves locally, and they can reflect with leading evidence as to what target action should be taken for improvement. But not only that, these tools will be able to give homes the mechanism to evaluate, to come back and review, is progress being made? That is so important, and that's this quadrant, and we'll hear more about that. We'll move left to the incident analysis workshops and facilitation that will be provided, and that will be so that homes can better understand why medications are occurring locally in your home, and by analyzing them, by selecting key types of errors and incidents that are happening and analyzing them. And then by defining and implementing targeted actions that will prevent them from occurring again. Then up to the top left, medication safety education and model practices, so that homes will be able to build their knowledge of the latest evidence on this topic. And it's a big topic. There's lots of knowledge out there. And then be able to implement recommended practices, policies that have been adapted to their local context. And the final area of support is teaching and coaching in quality improvement, so that homes can effectively understand their medication management processes and then make evidence-based changes that will be sustained. And with that, I'd highlight our foundational principles for the initiative. They, to begin with, so important that I emphasize all activities integrate across these 4 key areas to reinforce capability and capacity building. I'm sure as you look at all those areas, your first comment might be, and I welcome you to jump in the chat box and share what you're thinking, but you might think, well, those are all related. Those all have to happen, and you're right. And we've designed the initiative in a way to do that. The next one is all activities undertaken collaboratively with the sector. We know it doesn't work just to say, do this, do this. That never works. It's a journey, it's a collaboration. We're learning, you're learning. That's the way this initiative has been designed. And we're designing it in a way so that we're providing resources, expertise, many of them online asynchronous so that people out there can access them anytime. Some of them live interactive, some of them in person, in order to give that breadth and depth to homes to be successful. And finally, focus on resident and family engagement participation as part of interdisciplinary quality improvement teams. It's so important. We have a whole dedicated area of work in this priority. We believe that it is essential to effective changes and sustainability to have strong engagement. And so with that, over to Melissa, our patient and family advisor at ISMP Canada, to share more on this focus.
Thank you, Carolyn, and good afternoon, everyone. Residents in Ontario's long-term care are the heart of every home. They have varied interests and a rich history. They've reached a stage in their life where they need to rely on others to support and care for them. We know that there are some residents who cannot be autonomous in their own care, but there are many who are able to self-advocate and make decisions for themselves in their medication management. Working collaboratively between staff and residents gives the best possible chance for safe medication experiences. Let's listen to the words of this resident to hear about her experience with a medication incident.
I try to keep informed, and if I get something that I don't recognize in my little cup, I definitely ask questions. Because I had an issue at one time where they gave me the wrong medication, and I looked in the cup and I said to the nurse, "What's this?" And she said, "Well, that's what you take." I said, "Oh, no, that's not what I take." And I said to her, "Could you please go to the computer, bring up my name and my picture, and you will see the list of medications I take." And sure enough, she informed me she made a mistake.
We don't actually know what transpired after the acknowledgement of the error. However, those near misses are beautiful opportunities for reflection and change. Residents have an ability to support medication safety. Engaging their perspectives in all areas of this process will help to sustain continuous improvement. But how might we bring these important voices into the fabric of our homes? As part of the work that ISMP Canada is doing with the Ministry of Long-Term Care, we've developed an online toolkit that all staff will be able to access at any time. This is a central place where there are resources that staff can use to reflect on resident and family engagement in their home, to measure engagement opportunities and experiences, and to learn how to increase that engagement. Let's foster a culture of resident safety and continuous improvement by harnessing the wisdom of these incredible people and making them part of the infrastructure of care. That culture of safety must underpin our goals to embed residents and families into our improvement plans, and we know that it can be challenging in healthcare, but patient safety culture and resident and family engagement are closely intertwined and are reciprocal. When engagement increases, culture matures, and as culture matures, engagement opportunities become more evident and authentic. In the toolkit, you will find resources to support a continuous improvement model in safety culture. Active communication between staff during transitions of care and staff to residents and families is crucial to maintaining that culture of safety. Sometimes miscommunication can cause conflict, tension, and even medication errors. As we heard from Devorah in the video, communication can also prevent errors. Effective communication supports the culture that we are working towards and amplifies the voice of the resident and their family. To facilitate communication between residents and staff, we are creating a resident education module to help residents be as actively involved in their medication management as possible. When staff, residents, and families work together, safety increases.
I can't stress enough that residents need to know, or at least be involved in some way with recognizing their medications, making sure that the timing is correct. And they do make errors. It happens. It's unfortunate. There has to be some method, some means of helping residents determine, even if something is color-coded or designated for a certain purpose, at least to inform the residents.
I would like to be on the committee that decides how they're going to reduce errors so that I can add the resident's voice to that. I find the nursing staff very careful and watchful, and they very seldom give out the wrong medication.
The full-time nurses that know their residents are extremely careful and know exactly what they are doing. I have had opportunities to get to know my doctor. I've become very acquainted with him and he with me. And that rapport, that That bonded relationship is critically important for me and for many other residents in long-term care.
These are some really lovely relationships and interactions that Barry and Devora have with their providers, and there's such a great opportunity to integrate them into improving practices. They want to be involved, and they have great ideas, experiences, and clear message that stem from their unique perspective. Our residents and their families have wonderful contributions to make in their home. We hope that staff will feel supportive and will have an opportunity to take a deeper look into a variety of subjects. The examples presented here today are only a fraction of the tools available online. Engaging these wise residents in their care and medication stories will support providers as they continuously improve the incredible work that they do every single day. The toolkit is available on our website, and we hope that you will use it and share it widely. Thank you, and over to my colleague Alice Watt, who is leading the work in medication reconciliation.
Thank you, Melissa. Resident and family engagement is crucial to medication safety, as residents and family, like Barry and Devora, can be an extra set of eyes and ears to help prevent medication incidents. And this is especially true at transitions of care. Transitions of care refers to the movement of a resident between healthcare providers and settings as their condition and care needs change. For example, when a resident moves from the nursing home to the hospital and then back to the nursing home, we know that medication incidents can happen at these transitions due to gaps in communication and the lack of interoperability between siloed systems. To address this problem, our team is developing best practice resources for frontline staff that includes a model medication reconciliation policy and a template for documenting admission orders, or what we like to call the best possible medication history, shortened as BPMH. It's a snapshot of medications that the resident is actually taking. We're also working on an e-learning module about medication safety at transitions of care that highlights some of the risks and the prevalence of medication incidents at these transition points. And we'll share evidence-based interventions that have been shown to help enable seamless care and safer care transitions. We'll also demonstrate how to do a systematic BPMH with a practical step-by-step guide. One of the activities that I particularly enjoy is coaching teams, and we will provide individualized support to help you move forward. Why is there such a focus on medication safety at transitions, you ask? Well, not only has this been identified by the WHO as one of the 3 key action areas in the Global Patient Safety Challenge, Medication Without Harm, but the reason we need to focus on this is that the medication incident rates of 21% or more have been reported when residents move from hospital to long-term care. And up to 60% of these incidents are serious, life-threatening, or fatal. The types of medications involved that are on the top of the list are anticoagulants, opioids, and insulin. One of the incidents shared in an ISMP bulletin involved a resident who was transferred from acute care to long-term care facility. The information about the resident was sent from the hospital to the nursing home by fax. The staff at the long-term care facility copied the medication orders from the discharge summary and recorded potassium chloride 40 milliequivalents every 4 hours as part of the admission orders. The hospital had not intended to continue the potassium as it was only ordered for 2 doses. But unfortunately, due to the way that the hospital medication information was displayed, the order was misinterpreted as an active order, and the potassium chloride was unintentionally continued and given every 4 hours for 17 days. One of the residents, the resident was then transferred to the acute care hospital and was readmitted with hyperkalemia and died shortly thereafter. In this tragic case, the holes in the Swiss cheese lined up and the error bypassed the safety system checks that were in place. The BPMH is the fundamental cornerstone for medication management. And what that means is that the BPMH is the starting point from which everything stems from. And this requires a systematic approach. and involves resident and family where we can to get the truth about the resident's medication use story. This BPMH will then go on to become the medication orders. And then from there, the medication profile can be clinically reviewed to ensure that each medication is appropriate for the resident. And then we can look for opportunities to deprescribe and optimize the medications according to what really matters to the resident. And that's medication management in a nutshell. But it needs to start off with a quality and reliable BPMH. And that's what we hope to be able to help your team to do, to improve your processes using quality improvement methods, which my esteemed colleague Anurag Parag will tell you about next. Over to you, Anurag.
Thanks, Alice. So as Carolyn and Melissa and Alice have already mentioned, engagement is a critical success factor for any kind of improvement to happen. And quality improvement initiatives are really successful when everyone is engaged, all the different stakeholders, right from residents and families to physicians, nurses, PSWs, leaders. They're not only engaged in the initiative, but also see the success of the initiative as their own success. And that engagement is really brought about by a three-layered system. The first layer is the initial awareness building. The second is building the skills and capabilities. And the third is the coaching for improvement. Our initiative, Strengthening Medication Safety in Long-Term Care, is designed to cover all three aspects. On the next slide, we will look at the approach that we've taken for quality improvement education. So as I said earlier, the first step is the awareness building, and that we've designed short online modules that can be taken by anyone at their convenience. And when I say short, they're 15 to 20 minutes long. And these are to provide some basic flavor of the different quality improvement concepts to the learners or participants. Two of these modules are already live. The first two, the Introduction to the Quality Improvement Method and Workplace Organization. And once learners have gone through these, then they can move on to the advanced workshops where we actually talk about the how. These are longer 2-hour workshops and will be facilitated and will build on the online modules to provide a deeper understanding of the quality improvement concepts. The three, as I said, as the slide shows, one is on mapping, then designing tests of change, and how do we sustain improvements while at the same time working on change management techniques. On the next slide, we will look at the third element of a successful quality improvement program. This is where the coaching, the quality improvement coaching comes into play. For this initiative, it's a 3-year initiative. In the first year, we are going to work with 10 long-term care sites in Ontario to implement the quality improvement process, which will include measuring and mapping the existing processes, getting the baseline information, then figuring out what are the critical levers for change by analyzing data as well as doing following other quality improvement methods, and then identifying and testing a few critical changes to measure the impact on medication safety. In years 2 and 3, based on the knowledge we've gleaned from year 1, from the 10 sites, we will then spread this knowledge to all the other initiatives through a combination of education sessions, through a collaborative approach, and by conducting small tests of change at these initiatives. And the sites throughout will have access to ISMP Canada experts on improvement and medication safety. The next slides will show you a snapshot of the first education module. The goal of this is to really show you what the structure of these education modules is. All of them have been designed to follow a similar structure. In the beginning, we come up with a compelling why. For example, in this case, the first module is about the introduction to quality improvement. And we've taken information from the literature and we've translated that, extrapolated that to Ontario, and come up with this headline number: 90,000 plus medication-related injuries happen in Ontario nursing homes every year. Learners are asked questions throughout the module just to build that engagement and interactivity. And they get a few chances to answer questions like, how many of these errors do you think are preventable? In the chat box, you can actually enter that, if you know, just to get a feel for how these work. And while you're doing that, we will also then you will get, as a learner, you will get a few chances to get the answer right. And then, for example, here the correct answer is 40%. So now everyone understands, everyone gets on the same page as to why the initiative is important. Then we move on to a few more slides where we build a little bit more engagement. We don't just present the common medication errors, but we ask participants which of these common errors are most relevant to them, just to build a little bit more engagement, as I said earlier. So it could be communication, it could be not having standardized policies and procedures, overworked staff, etc. From this, we then move on to an everyday activity, or even sometimes a game, where participants will be taken through a scenario. In this case, they are asked to solve a traffic safety problem in an imaginary city of Grandowen. What this allows them to do is to solve a problem, but then also translate it later to their own sites. In this case, they are taken all through the steps of the quality improvement method. The first of them is shown on the following slide, which is writing a specific goal statement. Now, typically when you find in quality improvement courses, they just tell you the what, write SMART goals, S-M-A-R-T. They just define what those are and so on. But then what is missing is, why is that important? Because teams that write good SMART goals are 42% more likely to achieve them. Throughout the modules, these kind of tidbits from published literature are presented to the participants. In this quality improvement module, then they look at data and they select data that is ripe for more investigation, for deeper dive. For example, in this case, the 50% of the accidents, are happening between October and December. After they've talked about the data analysis, then they're taken through the whys. Why do you think mistakes happen? The choices are designed to present some options where teams typically make mistakes. We are too quick to rush into ascribing mistakes to human error sometimes, and we lose the fact that there might be systemic issues causing medication mistakes. On the next slide, teams are taken through the solutions that they've brainstormed and selecting one of the solutions available. Again, the options, as you will see, are designed to present the common solutions of adding more people, more equipment, more money, etc. But sometimes those are not the most elegant solutions. And finally, participants are asked to present or to write down how they would translate all this knowledge to their site. And towards the end of the module, then, they will look at, as you can see on the next slide, you will see a summary of the basic quality improvement steps. So that is the quality improvement program, including awareness building, education, and coaching. And over to my esteemed colleague, Dr. Mike Hamilton, who's our physician lead on the project, and he will talk to you about measurement.
Thank you so much, Anurag. The measurement of safety is challenging, but it's really necessary for quality improvement. How do you know you're getting better without knowing where you were before, where you are now, and where you want to be? So during this project, we'll develop a series of medication safety indicators that will help you learn how well you were doing in certain areas, and also point out areas where you do have an opportunity to improve. And we want to do this in a way that really reduces your data burden. We know you're already collecting and reporting on a number of things to a number of different organizations. So we do want to take that data and maybe repurpose it for medication safety, for safety in general, and for quality improvement. And we also certainly do not want to increase your reporting burden. So as we develop these, we'll have indicators about medication errors, about transitions in care, about involving residents in their care, about prescriber and pharmacy services, and about learning itself from safety incidents. The goal is not to collect data for the sake of having numbers, but the goal is to collect data so that we can use it to get better. And one of the best ways to get better is to have a collaborative and well-functioning team. I myself am a long-term care physician. I'm a prescriber. My whole team has a number of different individual jobs, individual titles, and expertise. But we're all part of the same care team looking after residents' health, and we all are invested in the healthy outcome of residents. It's really time we understood how best to integrate the medical director, the physician, the prescriber, all the other staff in not only providing the medical part of care, but in driving improvement through incident analysis and quality improvement. We can all get better at what we do, and ideally we all get better together as a team, and a team which includes residents. So as our project advances, we'll focus on ways to get prescribers and every team member more involved in safety and QI, including with incident analysis and self-assessment exercises that Julie Greenall, ISMP Canada's Senior Director of Projects and Consultations, will highlight in the next slides. Julie?
Thanks very much, Mike. And welcome everyone, and hello. It's lovely to have you all here this afternoon. My part of the presentation is going to focus on the updated medication safety self-assessment for long-term care. You may already know that we released Canadian version 3 in April of this year. This new MSSA includes a total of 176 assessment items, so it's a bit longer than the old one. 53 of those items are new, 75 are revised from the old assessment, and 48 are from the MSSA focus on never events in long-term care, which concentrates on strategies to prevent the most serious types of medication errors, typically those involving high alert medications. We're also really pleased that through the funding from the Ministry of Long-Term Care, we were able to make this version available in both English and French. A key source of new content in this version, as Carolyn mentioned, was recommendations from Justice Galiza's report related to medication management. We also derived content from analysis of medication errors by ISMP Canada and ISMP in the United States. And we included findings from a comprehensive literature search that was conducted for us by CADTH, the Canadian Agency for Drugs and Technologies in Healthcare. And we also included user feedback. For many years, users of our previous program had been submitting feedback, and I'm happy to tell you that we did review all of your comments and consider them in this updated version. This update includes a full section on medication system technologies, things like electronic prescribing, clinical decision support systems, and automated dispensing cabinets that are new to long-term care. The update of the MSSA for long-term care was supported by an expert advisory panel that included long-term care residents and family members, resident and family organizations, health professionals working in long-term care, health professional regulatory authorities and associations, and long-term care home associations. We also had the benefit of working with the Accessing Center for Expertise at the University of Toronto's Institute for Health Policy Management and Evaluation, and they helped us with the design and clarity of the assessment items. The new assessment was validated through a two-step process. First, it was field tested by 20 sites in March, and then each of these sites formed a team and completed the test version of the assessment. They were also asked to complete an additional separate detailed content evaluation, and 16 of the 20 sites submitted that for us. 4 sites were selected for follow-up interviews by the ACE team, and the ACE team held 11 separate interviews with people in the 4 sites that had completed the MSSA, and the intention of those interviews was to ask them for their feedback on the assessment process itself, as well as the detailed assessment of each individual item in the test version. And so the way they did this was they basically selected a section to review with each interviewee, so that over the course of the 11 interviews, they covered the whole assessment more than once. And each assessment item was reviewed for understanding, clarity, and relevance. And then we did incorporate all of that feedback into the final version. The current initiative by the ministry, the Medication Safety Technology application process, is encouraging widespread uptake of the new MSSA. And as of yesterday, June 22nd, 54 Ontario sites have completed the MSSA. And so you can see from these graphs that about half of the completing sites were from the for-profit sector, and then the other half pretty evenly split between not-for-profit and municipal and government sites. And you can also see that the most common size of the homes submitting so far is in the 100 to 300 bed range. This next slide shows a typical graph that an individual site would see. And as soon as you submit your data, you're able to receive comparative graphs. And these graphs help you to see where your home sort of fits relative to the aggregate data set. So when you look at this graph, you'll see that most of the graph has a yellow bar and a blue bar. The yellow bar indicates your home's results, and the blue bar is the average of the aggregate results. And then the red line shows the standard deviation, or the range of responses. And where there's no yellow bar, so for the first question, the home has indicated that this item is not currently implemented in their site. ISMB Canada can view the aggregate results for all the assessments completed, and this is the results so far for the section focused on medication system technologies. So you can see that some of the things that we know are not widely implemented in long-term care, so e-prescribing and clinical decision support, automated dispensing cabinets, and barcoding for medication administration, the scores are quite low, which is what we would expect based on the known level of implementation. And then things like general IT support and characteristics of pharmacy systems show higher scores. Now, one of the new features that we have implemented with this update is a collaborative group functionality. And we've been getting a lot of questions about this because the MSSA is really designed to be completed by an individual home. And we have heard that some corporate groups have previously done one assessment for all of their homes. We really don't recommend this because even with common ownership or governance, there can be substantial variation from site to site. So with this new collaborative functionality, individual sites are able to compare their own results to their collaborative or to the full aggregate data set, and the collaborative group leads can compare their group's results to the whole aggregate. They also have access to look at individual site results at the corporate level. And so this graph is an example of a collaborative group graph that would be viewed by the lead. And so in this case, the yellow bar shows the collaborative responses and the blue bar shows the average aggregate. And on the next slide, you can see this is what the collaborative lead can also see for individual sites. So if they have a group of homes, they can actually see the results down to the individual level. And this allows the ability to identify areas of strength as well as opportunities for improvement, and really supports developing a corporate quality improvement plan for medication safety. And just to conclude my section, I'd like to let you know that we're currently working on a user guide that will help you to optimize use of your results. So this guide will include detailed instructions and screenshots to help you navigate accessing comparative data, as well as a sample presentation template you can use to share results within your organization. And we expect this user guide to be available later this summer. And with that, I'm now going to hand over to Sylvia.
Thank you, Julie. I'm going to start by thanking all of you for the information you are providing in the chat. For example, the challenges being experienced in your suggestions, and some of them are longer standing challenges and a key opportunity for system-wide improvements and for working together. So thank you. One of the components of the Strengthening Medication Safety and Long-Term Care Initiative is to develop leading practice documents and resources, including model policies that homes can use as needed. So the key areas that we are currently working on in collaboration are model policies for management of high alert medications such as insulin, so that homes can incorporate the latest evidence or recommendations for safe use of these medications. We are also providing leading practices and model policies for medication storage in the home. So again, these will be designed so that they can be adopted or adapted by homes as is most useful to them. We will be preparing considerations and guidance related to the use of automatic dispensing cabinets. Currently, we are gathering information and learning about ADC use in long-term care homes, and we will also be drawing on our experience with the use of this technology in other settings. One other key area is our work related to medication reconciliation and the leading practices, and this was described earlier by Alice and Melissa, and again, your points in the chat are so well taken, so thank you. So now Shirley, she's going to let us know a little bit more about how we can work with you to establish standardized processes or a standardized approach to medication incident identification and response and analysis. So over to Shirley.
Thank you so much, Sylvia. Through the Strengthening Medication Safety and Long-Term Care Initiative, ISMP is dedicated to our objective of enhancing resident safety through a continuous improvement cycle of safe reporting, learning from our mistakes, improving our systems, and sharing the improvements with the sector. In the end, everyone wins, but most importantly, our residents. Our ISMP Incident Analysis team would love to hear about your successes in improving systems and share them with the sector via our newsletters. If you would like to share a report with us, you can use the Practitioners Reporting Portal, which is the purple button on our main page of our website. Incident analysis is an ongoing process. It begins before an incident and extends to the sharing of learnings within your home or with the sector. We are here to help you every step of the way, including support in drafting your initial response, information gathering, analysis, and implementation of findings. It is my privilege to work with some of the most well-respected medication safety experts in Canada and the world, including some of the authors of the Canadian Incident Analysis Framework, which is available on our website. Let us know how we can help you. How do we accomplish this through med incident analysis? The keys to success are ensuring the promotion of a just culture of incident management, including support for the staff involved in the incident. A diverse analysis team, including the involvement of residents and families, has proven to be very effective in having impactful learnings result from the analysis. Deep analysis of medication incidents means you keep asking why until you arrive at a well-defined finding. How can we support you in this process? We offer several tools to enhance your knowledge, including interactive virtual workshops. At these workshops, we not only teach you the concepts needed to complete different types of analyses, but also give you a chance to practice them prior to taking this back to your teams. We also offer email support if you have questions about the process or want to know more about what we can offer. You can reach us at ltc@ismpcanada.ca. Over to Carolyn to finish things off.
Thank you, Shirley. Shirley's our project manager for the initiative, and so you'll often see Shirley there and coordinating things. A big thank you to the entire ISMP Canada team. Your passion and expertise in this initiative is clearly evident today. So what I'd like to do as we work towards ending our webinar is close with a coming soon message for you. There will be a call for expression of interest in becoming one of the 10 champion site homes for the initiative. That call for interest will be going out in July. Are you interested in dedicating time, energy, and resources to becoming a champion site? Well, if so, really think that through. We're going to be going through a process where you'll need to share what kinds of time, energy, and resources you'll be willing to provide to become a champion site. And we'll take all of those expressions of interest and we'll identify 10 and move forward from there. What will we do with the champion sites? We'll work individually at each home, mostly virtually, but if we can in person, as that is possible, to obtain baseline self-assessments, map medication processes, analyze medication incidents with the home, adapt and implement model policies and practices. In the end, to take targeted, effective action to improve medication safety. There will be an additional layer of support to these homes to help make sure that policies, practices are plausible, can be adapted, can be effective, and so a very important role for those of you out there interested. All registered participants for the webinar today will receive the email with the information, and we will have details on ismpcanada.ca later in July, and we will be spreading it through all our communication mechanisms as well. So we'll try and get the word out as broadly as we can, and certainly look to you to help us do that. The 10 sites will be selected on a number of different criteria. I've got a few here. We want various sizes, various geographic locations. So if you're thinking you're small, out there in maybe, northern setting or rural remote in some other way, then don't think that you're out of this. We're interested in small sites, far from the large urban centers. But also, if you're in a large urban center, we're interested in you too. We want to have a good cross-section of sites based on size, geographic location, also based on experience, capability, capacity, and quality improvement. Different types of for-profit, profit, and municipal homes will be the mix. These homes will be very important, as I say, to test and learn together, and then to spread the word as well. We really do hope the sites will work with us to spread what has been effective to make it easier for all homes in Ontario to do the right thing. And with that, I'll close by sharing some of our contact information here, just to make sure you have it, to keep an eye on our website, to email us. But also I want to thank you so much for your passion, your commitment, your everyday work that you do to deliver safe, effective care to residents and families across Ontario. We recognize that. We recognize how busy you are. The idea is to provide resources, assistance, facilitation, and coaching that can be integrated into your busy days. We look forward to working with you. We will stay on till 1 o'clock Eastern to look at the chat box, the Q&A box, and dialogue with you around your questions and your comments. Would really appreciate hearing from you. What do you think about what you've heard today? Are you interested in more information? And we also have a quick survey for you to complete as well. At the end of the webinar, you will receive that. It's going to be so important to stay in good interaction and dialogue with you. And today we'll do that through the chat, the Q&A, and also the survey that you'll receive. And with that, we'll say bye for today. We'll continue to monitor the chat and the Q&A, and you'll receive an email with a link to the recording if you would like. And so I'll just check with the group. Rajiv or anyone else, any questions or comments you'd like to bring forward from the group to talk about as we finish off the next 5 minutes or so?
Thank you, Carolyn. I'm just going to launch the survey so
Thank you.
that those who are here with us can answer some of the questions. We would really appreciate your feedback.
Thank you so much, Rajiv. I'm just wondering, Julie, I saw a question in the Q&A about that great option of collaboration sites in the MSSA. Do you want to just share briefly how people can do that if they want to?
Yes, thanks, Carolyn. So if you're interested in participating in a collaborative, you can email us at longtermcare@isnbcanada.ca, probably the simplest. We also have an MSSA at isnbcanada.ca. What we will need is a list of the homes that you would like to include in the collaborative and the person who's going to be the collaborative lead, and we'll follow up with any other information that we need.
Thanks, Julie. Any of the panel or would you like to bring forward any other comments that you're seeing, questions that you'd like to address while we're on the webinar today?
Carolyn, there are a few questions in the Q&A. Would you like to go through those?
Why don't you pick one that looks good and we'll start there. We'll see how many we can work through while we have everyone answering their survey and we finish up to the top of the hour.
Alrighty, so the first one is, do we have to wait for July to show our interest in being one of those 10 sites?
Yes, is the short answer. We want you to think about it. We want you to go back and talk about it. These aren't individuals that we're looking for. This is teams from homes. We need the leadership. We need the staff, hopefully the resident and family, at least one or more representatives to be involved in the champion site work. So what I'm going to say the best option for today is to go back and start talking about it. Do you want this opportunity? Is it the right time for your organization to receive this additional layer of support, expertise, advice as you tackle medication safety? And it should be a very important collaborative decision. Again, things never work when top-down told to do it. So you really want to check and see, is your organization, the senior leadership, some of the staff, are they ready to commit some time, energy, and resources? And then when you get the email that we'll be sending out in July, if your answer has been yes, you'll fill out a call for expression of interest form, and that will come in. The best way is to fill that form out and submit it. And then we know that we've got your application and we'll be looking at all of those forms to make a decision. So hopefully that helps answer that question. Any other?
Yeah, so Mike had indicated as well that he might have something to add there. Mike, did you want to add anything, or did Carolyn cover everything for you?
That was all covered. Thank you.
Okay. All right. Wonderful. This one I think is probably good for Julie. What's the best practice in completing the assessment, the MSSA for long-term care?
Yes, thanks, Shirley. The really best practice is to form a team that includes members of your leadership, frontline people, and also include resident and family representatives. There is in the MSSA, it does list suggested team membership. And most of our test sites were able to complete it in 2 to 3 hours. So you may need 1 to 2 meetings to do the assessment, and ideally send it out ahead of time to everyone so that they can all review it in advance and come prepared with their idea of what the best answer is. There was also a suggestion in the chat about a webinar on how to complete the MSSA, given the new content. And we actually were thinking of doing webinars in the fall to talk about some of the results, but certainly we can think about whether we could do one before then.
That's great, Julie. And I think we're out of time. We're coming up to the top of the hour. Any of the questions that remain, we'll make sure that you get an answer back by email. Unfortunately, some of them are coming in anonymously. And so if you would like to let us know in the chat that you would like a response, that would help us to be able to answer these more effectively as well. So over to you, Carolyn.
Thank you, Shirley. And we'll also give everyone the option, if they've come in anonymously, or if you're just not sure they're going to get answered today, to email ltc@ismpcanada.ca. That way we know for sure we'll respond back to you. And so we are at the top of the hour. I will once again thank everyone. A big thank you to those taking time, and also to the ISMP Canada staff, and to Rajiv, who's ISMP Canada staff, for your amazing technology expertise and advice today. Very helpful. Take care, everyone, and we look forward to working with you and seeing you soon. Bye.